Good morning. I'm William Porter McRoberts, MD, in Fort Lauderdale, Florida. Today, I'm going to talk to you about epidurals. The good, the bad, the ugly, why they work, why they don't work, what's a good one, what's a bad one, are they dangerous, can you become paralyzed, why do we do them, why do we do close to 1 million a year, and everything there is to know about how to do them safely, how they can be ineffective, where we do them, the steroid used, when not to do them, the things that they do treat, the things they don't treat, basically every question you could possibly have about epidurals and why we use them in pain medicine, in pain management, in spine. And so let's just start by telling you what it is. So an epidural is a specific injection in a specific place in the spine. You don't get epidurals in the shoulder, the hips, or the knees, or anywhere else. Epidurals can only occur in the epidural space. The epidural space is, if you were to imagine best analogy is if you think of a water balloon and you've inflated the water balloon in an empty 2-liter bottle. And you've inflated to such a degree that the inner wall of the 2-liter bottle is now flush against the outer wall of the balloon containing the fluid. That's your spine. That is the cerebral spinal fluid inside the dura, hence epidural. Dura means tough. We call it dura mater, tough mother in Latin. But that dura is the sac that contains all the spinal cord and all the nerve roots in the lumbar spine. And so those all important neural elements are floating in this sac of fluid, and it's pressed out against the bony elements of the spine. And so that's why we have spinal stenosis. Those elements get thicker and press in. But the space is between the outside of the dura and the inside of the spinal canal, and specifically what we call the ligamentum flavum. So when we're putting medicine in an epidural space, the potential space is the same space. It's potential. It doesn't exist there. It's not like there's room there. When we inject fluid, it dissipates and it's squirted out, just like if you were to put a needle through the 2-liter bottle, but not through the balloon, and then inject fluid or medicine into that space. It would work its way around that bottle rather quickly and go up and down pretty quickly because the space is a laminar thin paper shaped space. It's not much. So what's the point? There's really two kinds. There's the labor analgesia epidural, or an epidural that you get before you have surgery, which is essentially just numbing medicine used with a little catheter. We put a little needle in, put the catheter up to the right spot, and then put in a local anesthetic and keep you numb in the distribution from that spot down. So your legs or your hips or your knees, let's say you're having a foot surgery, you can do that and essentially numb out the legs or the perineum where the baby is. But what we do in pain medicine is we're putting steroid into that epidural space. What is steroid? It is a hormone made by your adrenal gland. It's a natural thing. It's what our adrenal glands make every day, around 8 to 10 milligrams of which. But we hijacked the inflammation system because the body's reaction to steroid is that it systemically and locally reduces inflammation. And when we say locally, I mean if you put a little pin drop of this stuff wherever you have a tendinitis or any kind of inflammation, the local inflammatory response essentially turns off or slows down or goes away. And we're using that to our advantage because when in the spine you have a nerve root irritation, I'll show you some MRIs, and the nerve swells, and now let's say there's a narrowing of the canal or of the hole where the nerve comes out, the neuroforamen, the window where the nerve is coming out gets narrow, it starts to rub on the nerve swells, it gets large, and it makes less use of the narrow exit. And so as I say to my patients, we've got essentially two options. We can put the nerve on a diet and shrink the nerve back down to normal size. That's how we use the steroid in the epidural. Or conversely, surgically enlarge the doorway, which of course is spine surgery, and that's has its own concerns and successes. So the epidural is a chance to see if we can reset the problem. Now, what doesn't epidural steroid do? It doesn't do a whole lot of things. And for the most part, most insurances, they figure this out, rightly so, that, if you just put it in there for back pain, it really doesn't do much. It's not really indicated for that. And this is why the MRI is really so important, to be able to look at the MRI, and also why the actual location, the deposition of the steroid is so important, as it relates to the MRI, as it relates to your issue. It's all about location. But if it's simply back pain from arthritis, epidurals do very little. It might make you feel better for a little bit, but it's the dissipation of the steroid to the joints then that cause the effect. No need to really put it in the epidural space. What about degenerative disc disease? It does help. It depends on how it's placed. And so if the steroid is placed right against the disc where it's inflamed, much higher likelihood of success. If it's just willy-nilly kind of injected, it's not going to help much. And so I'm going to present a patient to you, a patient who had a definitive issue, had a facet joint cyst, and I'm going to ignore that knock and talk about that later. So the patient had a facet joint cyst, and the cyst is pressing on the nerve that exits and comes out and goes down the leg. And so this is an acute issue, but it's really a chronic issue because the underlying issue is the facet joint. I'm going to show you the MRI. Hold on. All right, so I think if you've looked at some of my other videos, you understand this is what we call a sagittal cut. This cut is right down the middle. So this is the skin at the back. These are the spinous processes. You can kind of see the spinous processes here. That's the same. And then in the canal, and then you're going to see canal here, nerve roots. This is the sac I was talking. The dura is this thin, you can't really even see it, but it's the line here. And then the outside of the dura is on the other side. That's the disc. So then you see bone, disc, aorta, guts out front. So, okay, so a little narrow. You can just kind of come back here and you can see, yeah, this is nice and open here. This is the way it should be. The patient, this lady had left-sided leg pain and thigh pain. So if you come over here, we can see the two relationships of these two cuts to each other. This thin purple line is the scout line that shows us where this slice occurs. This slice is right through the middle of the back. The head is that way, the feet are that way, this is up, this is down, posterior. So I've caught the cyst in action. So you can see here, and I'm gonna zoom in so you really can see, but if you see here, the hole where the nerve comes out is open. Here, there's the cyst pressing in on the canal, okay? And if we go up or down, you can see there's the cyst right there. It's really filling what we call the lateral recess. And you can see the nerve right here is the one getting compressed. And here's the little facet cyst coming off the facet joint. That's the fluid. Little inflammation in this joint overproduces fluid. The fluid has no place to go, so it makes a facet cyst and it compresses the nerve. So coming back, you can see if we bring this slice over, it'll be more obvious. So now I'm going to come over and you'll start to see, look at it. See that little cyst right there? That's the rascal. That's our perpetrator, as I call him, right there. Okay. So this is kind of a little basic of the MRI. You go to the other side, not really too bad. You come back to this side. And so the mass effect of the nerve, or rather the facet cyst against the nerve, causes compression of the nerve and thus the issue. So the reason I bring up this MRI is I'm lucky enough to have some of the fluoro shots from an epidural that was done, not by myself. I didn't think that the steroid was placed in the right position. The patient didn't have an effect. And then the patient came back to me and I placed the medicine where I think it was more effective, and the patient really did have a dramatically different reaction. I'm essentially pain-free. I did one after that and the pain is gone, and she's been out living life and traveling and cycling and doing all the things she loves with no back surgery. So, but it's about placement and it's about where the medicine goes, which is very important. Why? Because it's kind of like anything, location, location, location. But if it's not placed in the exact spot, it really doesn't work well. And so you think back to the studies that are done about epidural steroids, the argument that epidural steroid is ineffective or doesn't work. really it works for specific things and it doesn't work for other things. And that's the way of most tools. You know, if you say, you know, hammers don't work for screw problems, that's true. Don't throw away your hammer, you got to wait for the right problem. And that is true of epidural steroids. So I'm going to show you these fluoro shots, and I think you're going to understand why location matters, why probably experience matters, and picking your doctor well to some degree. You know, I got out of fellowship and I could have done around 1,000 procedures in fellowship. That's quite a few, actually. I know people come out of fellowship with, you know, 100 or 200. Well, it wasn't just, you know, a few years later I had 10,000, and now 50,000+ and, you know, and going. It matters because, to be honest, you know, I'm 53 and I've done well over 50,000 epidurals. I still think I get better and better, which means that, you know, what does better and better means? It means less pain, even better and more accurate placement. Just because the tiny nuances of doing something tens of thousands of times, you do get better. And you get better at reading the MRI, you get better at knowing precisely where to go. That isn't to say there aren't good guys out there. I've seen some really wonderful hands who are young. But let me just show you the MRI and you'll understand why sometimes it works and sometimes it doesn't. Here we go. All right, so a fluoro shot is an X-ray. This is what we use when we're doing the procedure. We use digital live X-ray to place the needles. And so here's kind of the analog. I'm going to show you, and from this kind of position, you can see the spinous process. That's this thing right here. You can see what we call the pedicle. So that's the projection of this thick part of the bone. You can see the disc here. There's the nerve, okay? And so there's the needle here, okay? And there's another needle here. So this is L3 and L4. And so that's where the needles are placed. And if you were to think about where the cyst is in the spine. It's deep actually to the facet joints. Right in there is really where it is. And you can kind of see the facet joint over here. There's the facet, there's the cyst, just deep on the interior portion of the spine. Okay, so how do we get medicine there? Well, there's a couple of ways. One is to come from over the ear of the Scotty dog right here. Hopefully the nerve's not there. And you wrap the needle around on the inside. Just follow the bone around and then come up underneath and then aim down. You'll get medicine right there. And then conversely, you can come right here and trace and put the needle right here, have the medicine follow the course of the nerve up where it's compressed just deep to the facet cyst. So here's another epidural. I didn't do this one. Needles well placed by pretty much any. You take this to any course director. They say, yeah, that's a good epidural shot. Look, here's a lateral, needle in the foramen, needle in the foramen. Here comes contrast. Following the nerve root out. This is a well-placed epidural by most standards. And another one here. Here's contrast flowing the nerve out. What you don't see is contrast in and deep to the facet cyst, which is right here, which is the target. That's what matters. It's just not there. So I'm going to show you what I did. Okay, here we are. Similar picture. Okay, to the last. Similar orientation. Again, I'm a little more oblique in my approach. So now we have what is called the chin of the Scotty dog right here. I'm right here, or actually right here, more specifically. And the problem is deep to this joint, okay? And so here's the needle right here. Let me show you so we put in contrast first, which is a little radio-opaque inert fluid that predicts the flow of the steroid. But okay, so now you can see needle here. Here is the flow of the steroid right up the interior portion, right next to and deep to, this is where the facet cyst is, right here. So you can see that contrast, no contrast, contrast. So when we switch syringes and then inject the steroid, it's gonna flow in the exact same location. And indeed, here's another little secondary washout, we call it. So I've injected the steroid, it's pushed the contrast out, and you can see now here's the contrast pushed away. The medicine is sitting just deep to the cyst, flowing around the nerve root, the exiting L4 nerve root right here. Okay, and so then the next backup shot is where we come down and I place the needle up right here, just in front of the ear. And I'm placing, and then you see the contrast flowing again around from in front of the superior articular process, again, right in front of the joint. There's the contrast. Some leaking out here too, of course. But that's the consequence of a well-placed, that's what it looks like to have a well-placed epidural steroid. Let's go over to, here's the other shot I did. Similar, there's the needle. This is totally different days, this is about a week later. Pain's coming back a little bit, but still doing pretty well. So here we go, flowing right into the foramen and right in and up next to the joint. The joint and the nerve and the cyst is right in there. Again, I come up and do it again right here. So that's what it looks like. That's a well-placed epidural in my opinion. And so what's the difference? The difference is being out and active and rejoining your life versus possibly having a facet cyst aspiration, which is another different procedure we do. More importantly, maybe a surgery to go in and remove the facet joint and the cyst, and not getting better. So when people say epidurals don't work, I have to find an argument with that. In the right person, the right patient, with the right hands, I think it's not going to fix everybody, but it has a definite impact and can change the course and the outcome of the disease process. Now, I did this epidural, it's September now, end of September. I did it early spring. Been doing fine. She has. What's the be all and end up? What does this mean for her ultimately? Will she may have to have it removed, but quite honestly, I see people in the grocery store years after epidurals who never needed anything else. And it may be the degree of the disease. If it's a big squeeze, if it's a big underlying facet joint, not the cyst per se, but let's say the thickened actual bone from arthritic spurs and overgrowth, honestly is hard to fix. You might reduce put the nerve on the diet, but it may not be a permanent solution, which is why we have all these other surgical solutions, and those are getting better and better. So what we also don't talk about is steroid. And some years ago, you may recall, there was a big deal, a big expose on epidural steroids, and doctors spoke on the Today Show. And what happened was one of the compounding pharmacies who was making epidural steroids had a contamination, and there was a mold that was then injected from contaminated steroid into the spine. It became a big problem for many people. I think about 8 or 10 by recollection, I don't recall. But they had abscesses, they had infections in the spine, which require essentially surgical debridement. And that was a big deal, certainly a big deal for those people. But again, this gets to the relative risk. We do hundreds of thousands, if not millions of epidurals a year in the US. For the most part, they're performed safely. Now, of course, there is risk. We're placing a needle. Imagine that. Think about putting the needle underneath and through the outer portion of the 2-liter bottle, but not nicking the balloon or injecting into the balloon. That takes a little to doing. And so that's why there's different routes also. Some are safer to do, some are less safe to do. And this idea of safety, you're putting a needle inside the spine. That does not mean it's like, there's inherent risk in everything we do. Don't think you're gonna have a wart removed without risk. Your drive to the wart removal has risk. Everything in life has risk. And is it 1 in 100, 1 in 1,000, 1 in 2? Think about that. Some of the things we do, you ride a bicycle down the street, it's risky. You put on your helmet, all the risk did not go away. You put on your seatbelt, people die with seatbelts. So the idea, the concept of risk, you have to understand what we're doing is we're trying to make you better. And what's the risk of not being better? What is the risk of death if you can't walk? Honestly, as we know, folks who have a knee replacement cut their cardiovascular risk in half. Why? Because they can walk and they're functional. So all of these are to try and help people be more functional, because function predicts longevity and good health. Cardiovascular disease, osteoporosis, diabetes, all of it gets better if you're functional and you can do what you can do. If you can't, the whole machine suffers. So let's talk a little bit about routes. So I just showed you what's called a transforaminal epidural. There's essentially 3 or 4 kinds. So that is where you go through the opening, and I'll show you right here. You're going through the side. The trans means through the foramen, or window in Latin, neuroforamen, nerve window. So you're putting the needle here. You're not even going inside the spine, to be honest, in a transforaminal. You're staying on the outside and squirting the medicine on the inside. It's kind of like a fireman standing on the street and aiming the flow through the hose through the open bedroom window into the fire. That's a transforaminal. So, I just showed you what that looks like. In the spine, you can also put a needle into the interlaminar space. So placing the needle down and into between the lamina, it's kind of the old-fashioned technique, what was done, because it's easier to do this. You can feel this in a lot of people, and you kind of get your mark. A lot of people do this blind. Most labor analgesia is done blind. They just feel around those anesthesiologists and come right down, touch the bone, and then they walk here, and then they use a loss of resistance technique, which is interesting. What happens is the needle, now placed down next to the lamina, then as it works up into the spot between the lamina, there's a ligament called the ligamentum flavum, the yellow ligament, and it's pretty robust. And so the needle is then, you switch syringes and you put a little fluid in the syringe with some air, so you have a limb between the water and the air. And you can see, put a little pressure in there, so there's compression. So now what stops the water from flowing is the ligament against the tip of the needle. But as soon as the very lip of that needle breaches and passes through the ligament into the space, through the 2-liter bottle, through the plastic, and then just the very tip of it passes into the space, then the pressure in the syringe advances water or saline, normal saline, out through the syringe, through the needle, and pushes the dura away, and then the needle's now in the epidural space. And we use that moment of loss of resistance to indicate, using this, that we're in the epidural space. And we can cheat, we can use the fluoroscopic guidance to do it. We can use the fluoroscope and see, then we put the contrast in, and we can see how the spread of contrast exists. And the spread of contrast, and if you go too far, you're intrathecal. But that's how we do a myelogram, for example. So it just depends on what your target is. But as you pass through the epidural space, now you're in the potential space. You inject the contrast, and it flows just like you would imagine in a confined space a little bit. It flows up and down because there's very little room between those two elements, the 2-liter bottle and the balloon. It looks very different than if you pass the needle through and into the balloon. You can't really pop this balloon in the back, but you can pass into it, and then you put contrast inside the thecal space. This is what you do when you have a myelogram. So you inject the contrast inside, it flows with the cerebral spinal fluid, then you go get a CAT scan. You can see the interior of the space because the contrast shows and highlights that. Otherwise it's just black. We can't see it well. So the epidural interlaminar type is just like I explained, using loss of resistance. We can do that throughout the neuroaxis. We generally don't do that above the cervical-thoracic junction or high into the high neck, just because in those folks, in most people, there's variability of the ligamentum flavum, so it may not even be there. It's hard to do the loss of resistance technique. So we can start in the thoracic spine or at the cervico-thoracic junction, then use a little catheter, just like the anesthesiologists do with the pregnant ladies. They put the catheter up the spine. We do the same thing, but we can actually see it on the fluoroscope, so we can direct it and steer it. And how injurious is that? Well, the catheter is, as I say, it's as injurious as a wet linguine. It has a little stylet, so it has some structural integrity, but the tip is essentially a little tiny spring. It's very gentle. So it's hard to injure people. And it's hard to break through the thecal sac, through the dura, with it, because it's kind of like if the catheter is going up the inside of this potential space, it's hard to take a right angle and then go through something. Very challenging. It almost never happens. But we can steer it. So that's the approach of using a catheter inside the spine. So if you're not getting the contrast and the medicine inside the spine, that may be another technique to use. We used to use it a lot in the cervical spine, but there's some arteries and veins, and so occasionally you could get a bleed, and then that would compress the spinal canal, and you'd have to take the blood out. That is one of the risks of that procedure. And so we do the transfemoral also in the neck. There are different ways to do the transfemoral in the neck. From the side, you can do from the back, come around, and then just hide the little needle there. There's different needle types. There's probably 30 or 40 different types of needles that are used for epidural placement. Some are big, some are small, some are curvaceous, some have side ports, some are sharp in different ways, some are blunt, some have pencil points, some have bullet points. All of these different needles exist because the practitioner, just like a golfer, if you're looking at a situation, you want to pick the best chance. You pick the needle that fits the anatomy of the patient the best and has the lowest chance of risk. So that's like a blunt needle. Why do we use blunt needles? Because it's been shown time and time again to have a very low risk compared to a sharp needle in cutting an artery, in cutting a nerve, and we don't see injuries with blunt needles like we do with sharp needles. Because if you can imagine, that little needle has a little short arm, a little bend on it. You turn a sharp needle, and the tip will act as a scalpel and cut. And you try not to do that, but it can happen. So the blunt needle, it's blunt. It's just very, very challenging to have, that cut anything. It just doesn't happen. So in the neck, we generally use blunt cervical needles with side ports if we're going to do a transfemoral. Then there's something called the caudal, which is the old-fashioned way, which is a way where at the base of the spine, right at the top of the butt, basically, right at the cleft of the buttocks, there is the base of the spine in the sacrum. There's a little arch and there's a little window called the sacral hiatus. And blindly, this is a very easy shot to give. We can pass the needle down into the base of the sacrum and then in. And now you have access. And quite honestly, you can put a catheter right up to the cervical spine. It's a long way to go, and it's kind of like running the hose from 2 streets over to the house on fire. It's kind of pointless if you have a hydrant next to it. But the effect is the same. You can place the catheter up through the needle and next to the problem area. So, okay, choice of steroid. I talked a little bit about, we got into issues and risk and that kind of stuff. So in the neck, some folks, the arteries that are there can pass by on their way to the brain. And so even though we're looking at the screen and we can see the flow of the contrast and we can see the needle position and we can correlate it to the MRI or the CAT scan, still it's possible to put the needle inside an artery, which is what we try and do when we start an IV, for example, or start a catheter, to do a heart, valve or stent. It's not, the problem is not putting something or the needle into the artery. The problem is then if we inject particulate steroid into the artery, because then the little particles can travel on to their destination and possibly clog an artery. And whatever's beyond that artery, within the watershed of the artery, then doesn't get blood. And you can imagine that can be an issue. I would say it's kind of like if you throw a golf ball into the municipal water supply, it goes into the main artery. It's a big tube of water. It goes down to, a neighborhood. Now it takes a left on Elm Street. Now the pipe's, the size of your bicep or your forearm. And then it goes and takes a left at the Smith's house. And now the pipe is smaller than the golf ball and it stops the flow of water beyond and in that pipe. Same thing can happen with a particle in the neck. And what is the chance of being in the artery? So you got to weigh that risk. Honestly, I think it's extraordinarily rare, probably 1 in 10,000 with experienced hands, probably less than people who are just getting out of fellowship or who've never had a fellowship for that matter. But nevertheless, it can happen. So let's say we're placing the needle next to now of course the intent is not to place it in the artery, but let's say you inject contrast and you miss that some of the contrast flows in the artery, and that artery is on its way to the brain as opposed to the tissues of the neck, and you inject some particles in the steroid, it's possible to have a tiny little stroke. And that has happened. And so it has never happened when we use non-particulate steroid. So the problem is that we now have had a few cases. When I say few, I mean it's not many, but it's enough. And if you're that person, it matters. I mean, it definitely matters. But we've had a few cases where people have had bad outcomes with the cervical epidural with steroid that's particulate, causing a stroke. It has never happened in the history of medicine if we use steroid that doesn't have particles. So we don't use particles in the steroid in the neck. But the problem is that because of this risk, and albeit a low risk, we now are essentially using a steroid that I think has low efficacy. The point of the particles, why do you even have them, is because they are long lasting and they have a depot effect. So those particles, when they are injected and they're around a nerve root, they may take months to gradually dissolve. And in those months, it's gradually dissolving and providing a depot effect. It's kind of like if you gave someone a vitamin for a day, no impact. But if you give someone a vitamin every day for the next 4 months, now you're going to do something. And it's the same thing. The particles elute the anti-inflammatory effect over every day, every hour of that day, every week, and then into the months. And that is what has a dramatic effect. Now, quite honestly, we haven't been able to show that with prospective randomized controlled trials. And that's the argument that people use, that, well, there's really no difference between the steroids. Well, I tell you what, if you believe that, you just haven't done enough epidural steroid injections and you're not a student of the game, because there is a difference. And so that is why I tend to try and use particulate steroid in the lumbar spine, where the risk of being an artery that goes to any vital structure is extremely low. Not zero, but extremely low. Because why would you do a procedure and take the risk of the procedure if the effect is minimal? Then you just go to surgery, which we all know has significant risk. So this is a stepwise game theory approach to try and figure out why you do things and why you don't. Could there be in the future studies that show that epidural steroids placed with certain techniques are safer than others? The particulate steroid? Yes, we don't have those yet. So we simply don't know. And also we don't even know, even though we do all these procedures, we don't keep good records. Like, what is the risk? Would you risk something that's 1 in 100,000 to get a good outcome? I would. 1 in 10,000? Yeah. 1 in 1,000? Maybe. 1 in 100? Now we've got to really make sure that 1 in 5? Okay, no, probably not. And understanding that risk likelihood ratio is essential in everything in medicine. I'm sorry we're onto this, but it really does matter, because the perception from patients, I just got a text during this very video that one of my patients worried about an SI joint fusion. She should be. What's the risk of something going wrong? It exists. It's not zero. Is 5%? Probably less. But 1 in 20 is 5%. Let's say it's 1%, 1 in 100. You got to know that nothing we do is risk-free. What's on the other balance of that? And really, the decision is, what is the risk to you if you do nothing? Just staying the way you are. That risk is high, because we know that the risk of sitting is equal to smoking. If you're sitting because you can't walk around, you might as well be lighting up a pack a day. So inactivity, not doing, is incredibly risky. That's the whole point of this. And that's why I say, as a physiatrist, we're not practicing necessarily pain medicine. We are. But what we're really practicing is functional improvement. And if we can get you doing the things that you need to do with an epidural steroid, quite honestly, I think it's worth the risk, because I think the consequence of living in pain and not doing is far greater than the actual procedure. Now, of course, there's variability in all of this, and it depends on the hands of your injectionist, your surgeon. What are the competitive alternatives? Could physical therapy work? Do it. It's pretty low risk, not zero. They might break something, they might make you worse. It's not zero. You might get in a bad accident on your way to your physical therapy or your chiropractor. Nothing to zero risk. Anyway, I've rambled on. I hope you have some understanding of epidural steroids, the good, the bad, the ugly. I could talk on and on another couple hours, but these are the minutia that keep docs up at night, like myself, trying to pick the very best thing for you, so that you get back to life, because it's a short one and death is a long time. Please comment if you have any questions. I'm sure there's going to be issues. I get comments all the time about this, but this is life. It's good to be having these discussions. Take care. Feel better. Get well.